I'd like to thank our co-partners. We don't do sponsors for this event. There's no money exchange, strictly just partners that help us spread the word and increase visibility for the importance of understanding the value of omega-3 in testing. So FARI, the Fatty Acid Research Institute, Carlson Labs, Nordic Naturals, Yoli, Vivo Omega, OmegaQuant, and GoEd and Nutraceuticals World. So thank you for helping us spread the word of this conference. So as we get started, I'd like to introduce a little bit more about Dr. O'Keefe's background. He is a board-certified cardiologist and director of the Charles and Barbara Dubach Cardio Wellness Center and co-director of the Haverty Cardiometabolic Center of Excellence. He's authored over 475 scientific articles. His postgraduate training included a cardiology fellowship at the Mayo Clinic in Rochester, Minnesota. He is actively involved in both patient care and research. He lectures extensively on the role of therapeutic lifestyle changes and drug therapy in cardiovascular risk reduction. Dr. O'Keefe, thank you so much for being here and sharing your expertise today.
Thanks, Tavis. Yeah, it's great to be here, and thanks everybody for joining us. This is this is a personal passion of mine, omega-3 and health, especially heart health, also brain health, but also Dr. William Harris, Bill Harris, and I are dear friends and have been for decades. I talked him into coming over from University of Kansas to St. Luke's Mid-America Heart Institute back in the 90s, and he spent several years with us. And we've been doing research together and conferences together for a long time. And I just think the world of Bill. And the OmegaQuant company is something we refer our patients to a lot for the omega-3 index. And yeah, so I'm going to tell you a lot of science that we've been doing, but a lot of sort of personal insights too. I do take care of a lot of patients. That's my I'm predominantly a clinical cardiologist, but do a fair amount of clinical research and have a preventive cardiology fellow. Omega-3 is one of the things we really emphasize, and I feel like I'm a bit of a voice in the woods because a voice in the wilderness, because so many physicians are dismissive of nutrition. Like I went to school till I was 33 or 34 before I finally launched as a full-fledged cardiologist, and I received exactly zero training in nutrition. So to the extent we know anything about nutrition, it's self-taught, and supplements are even more sort of kind of a source of skepticism for physicians. So omega-3, despite all of its data, I mean, most physicians do not recommend it, and certainly in cardiologists, with the recent data about atrial fibrillation, which I'm going to cover a little bit too. I know Dr. Chin's going to cover in the next lecture, but most physicians, rather than advising omega-3, they'll advise their patients who are on omega-3 to stop it, which I think is a travesty, as you'll see as we talk about it. There's never been more data, and lately we've been doing these collaborative research projects that really show the power of omega-3. Like a personal story, like I grew up in North Dakota near the Canadian and Minnesota borders, and even as a kid, I had figured out that like there was something about like sardines, or when I would get seafood, it wasn't like something that we ate regularly, but I associated, like when I would eat that, I would feel better. And it's really amazing. Like there's a million supplements out there. But one of the things I sort of pay attention to is how things affect our pets, right? We have 3 dogs and a cat, and our current dogs are aging better than any of our other dogs have. And we have been really faithful and regular about giving them omega-3. They have an omega-3 fortified food, and then we give them omega-3 capsules every morning, relatively concentrated omega-3 capsules. They have shiny coats and they're happy, and like I said, they look and act younger than their ages. But what I love about that is like it's so personal, and like we love our dogs, and so it's really fulfilling. But it's also like placebo doesn't work in animals. Like you can give somebody a placebo pill and tell them this is amazing, it's going to make your joint pain better, and you'll be thinking more clearly, and your heart will be healthier. And there's a good chance they will feel better just because of the power of placebo. But placebo doesn't work in animals, and so these benefits, and as most dog foods now are fortified with omega-3. For that reason, people notice that omega-3 makes a difference in their pets' health. So I'll just start off talk a bit about the omega-3 index. It measures the amount of EPA and DHA in the red blood cell membranes, which correlates very strongly with the amount of these omega-3 fatty acids in the neurons and in the cardiomyocytes and the rest of the cells of our body. But like in the brain and the heart, that those organs tend to work better. These electrically sensitive organs tend to work better when the membranes are optimized by having, sufficient EPA and DHA in the cell membranes. It keeps the cell membranes more fluid, more electrically responsive, and less inflamed. And so the omega index just looks at like, for example, you take this little chunk out of the red blood cell here, and count up the omega-3 fatty acids in the bilipid membrane. That in this case, in this sample, there was like 4 of the 64 fatty acids we looked at were DHA or EPA, so the omega index is about 6.25%. And I believe the DHA makes up the majority in the human cell membranes of the omega-3 that's in the cell membranes. So a desirable omega-3 index is about 8 to 12%. There's evolutionary sort of hypotheses that say the about 50 to 100,000 years ago, the giant leap forward in human cognition probably correlated with when we were moving along migrating along the shores and starting to eat a lot of omega-3 in the form of shellfish and fish, that humans had started to do that, and that correlated with this expansion in the brain size and also in just the cognitive ability to think in abstract and develop language and whatnot. But so evolutionarily we're meant to have an abundance of omega-3 in our cell membranes, and an ideal index is 8 to 12%. In the US, it's usually kind of more in around the 5% range, 5.3% range. And it's quite common to see people who don't like fish and don't eat much fish at all to have levels under 4. So in Japan, typically they have a range above 8%, even if they don't take supplements, because they eat fish every day, oftentimes multiple times a day. In the US, 90% of Americans have an omega-3 index of less than 8%, 9 out of 10. Supplements are generally unnecessary except for those essential nutrients, important nutrients, for which we tend to be deficient. So that's why, to me, omega-3 is right at the top of the list. I think most people should be on an omega-3 supplement if they're not eating fish multiple times a week. And the type of fish we're talking about, you're like fatty fish like salmon or sardines or mackerel tend to be the highest in omega-3. And so those are the ones I tell my patients, salmon is particularly a great choice. Sardines are another one, but it's a bit of an acquired taste. A lot of people won't eat sardines sort of voluntarily. But yeah, so omega-3 is among the most important, if not the most important supplement for most people to take, because it's so essential for cardiovascular and brain health, and also keeps inflammation down. But because, most Americans are deficient in it. It's like vitamin D is another really important one for most people to take, for the same reason that most Americans are deficient in vitamin D, and their immunity and bone health will be better if they're taking a vitamin D supplement. Lots of times like in our omega-3 supplements, we have DHA fortified in it, so you can take both at the same time. But so the thing I like about measuring omega-3 in the blood with like the omega-3 index is that it's a very objective measurement. The only way you get the DHA and the EPA at high levels in those cell membranes is by consuming it, whether it's fish and seafood or algae or with supplements. And so it's one thing to ask people, a lot of omega-3 studies and dietary studies in general ask people, how much fish do you eat? How much red meat do you eat? And that's a very unreliable metric because people often, don't exactly know how much or recall exactly how much fish they ate. And lots of times they're, whether it's conscious or subconscious, not being, fully honest. But when you look at the omega index, for sure it's like what their omega-3 status is, and it correlates with various forms of heart disease, as we'll be talking about in the coming minutes. It correlates with cognitive function, things like bipolar disorder, ADHD, depression, age-related macular degeneration, and several other things, of which we're doing a fair amount of studies with these giant databases like the UK Biobank and the FORCE consortium, which is a fatty acid consortium of studies that have been done over the past few decades. And we share data and harmonize the data, and can look at hundreds of thousands of people followed for 10 or 15 years and look at these various how omega-3 levels correlate with various health outcomes. So it's really powerful data that Bill Harris and I and my son Evan O'Keefe and Nathan Tintle, our brilliant biostatistician, and others have been working on, but it's a really fun collaboration. So this was a survey of 370 U.S. family physicians, and they asked about their own personal omega-3, and they 50% of them, 51% thought that their omega-3 would be in the desirable range, but in fact, when we checked it, is like 5% of people were of physicians had an omega-3 index above 5%. So a lot of people think they're getting enough fish, and it's a funny thing that my wife Joan and I've often commented upon. Like we ask people, do you eat fish? And I said, yeah, I like fish. I really like fish. Yeah. So how often do you eat it? Well, I mean, I don't eat it maybe once a week or a couple times a month, but I really like fish. So it's, just liking it, it's not good enough. Just like buying an omega-3 supplement, if it sits in your cabinet, it's not going to do you any good. You have to swallow the EPA and DHA. So, how much EPA and DHA do you need? This is a study done by Bill Harris and colleagues showing that taking omega-3 supplements does correlate with your change in omega-3 index, and that when you go from 0 up to 1,800 milligrams of EPA plus DHA per day, you see a change in the omega index gets up from around like low of 0 to up to closer to 7 or 8% to where we like it. I think for my cardiac patients and patients just concerned about general health, I often tell them to take between 1,000 and 2,000 milligrams of EPA plus DHA per day, and I generally recommend it in a sort of a balanced mixture. Most things like seafood and fish have an EPA and DHA that's in the middling range, 60-40 or 40-60. So getting equal amounts, and there's good data suggesting that like EPA might be better for reducing inflammation and DHA might be better for things like brain health. And so putting the two together, I think, makes a lot of sense rather than taking just one or the other. This is another sort of hypothetical regimen based on like the threshold effect according to baseline omega-3 levels. If you're eating a lot of fish like the typical Japanese would, and you wanted to keep your omega-3 index high, it wouldn't take much, maybe 500 or 1,000 milligrams of EPA plus DHA per day, like over here. If you're a low baseline omega-3, you might need more like 3,000, like 3 or 4,000 milligrams of EPA plus DHA per day. But like with blood pressure or a lot of things, one of my favorite sort of economic axioms is somebody got a Nobel Prize for this decades ago, but the first step in changing anything or managing any parameter is measuring it. And so, measuring the baseline omega index is a really, really powerful way to improve your omega-3 status. And it's probably for a lot of people, the most important step is measuring the omega-3 level so that you know where to start, and then you get them on a supplement, and then you recheck it, and if it's not above 8, then you increase the dose of the omega-3 and or increase their fish intake. So let me tell you about some of the studies that we've been doing in the last 3 years that correlate omega-3 with various cardiovascular outcomes. This is one that's just been accepted, hasn't appeared in online or in press yet, but this was looking at the Framingham data about over 2,500 people followed for 12 years or so, 12, 13 years. And we're looking at the omega index as a risk factor, and if it improves the standard pooled cohort equation, which is a modified Framingham equation, looked at multiple risk factors like age and gender and blood pressure and diabetes and HDL and total cholesterol and smoking, various things to predict who's going to get heart disease, and then test it to see if it actually accurately does predict it. So what we're asking in this study is, if you add the omega index to these standard risk factors, does it improve the prediction of risk? And the bottom line was that, yes, it powerfully improved the risk. In fact, it was better than cholesterol or smoking as a predictor for future risk of heart disease. And it added, in this case, it just looks at, without the omega-3 index, the pooled cohort equation, what the improvement in area under the curve, which is the improvement in predictive capacity. And for each one of these, smoking, total cholesterol, diabetes, HDL cholesterol, and blood pressure, in the green bars are better than the orange bars that at predicting it. So omega-3 is an independent predictor of risk, and it adds to standard state-of-the-art risk assessment things. That we use this lots of times in our patients when we see them in the office, and we add in all their clinical data, lots of times even like their calcium score, and and we say, oh, your 10-year risk of heart attack, stroke, or cardiac death is greater than 7.5%, so you need to be on a statin. That's an important sort of exercise we do for a lot of our patients to determine who needs to be on a statin. But this shows that the omega status is also as important as the other risk factors. And the other really important thing about this is that this is so eminently modifiable, right? You just need to swallow more omega-3, whether it's fish or supplements. This is like such low-hanging fruit. And if people understood and doctors understood the independent power of this risk factor, it's like blood pressure and cholesterol to me, and now diabetes with these new diabetes drugs, the SGLT inhibitors like Jardiance, and the GLP-1 agonists like Mounjaro or Ozempic or Zepbound for weight loss. And we love these drugs because they lower A1C, but more importantly, they powerfully reduce risk. So omega-3 is again in these same parameters where, like, it's easy to modify, it's inexpensive, it's safe, and we just need to be measuring it so that we know. This is just looking at the gray down here is a lot of the risk is conferred just by sex and by age, but this is the additive risk. And over here on the right, you can see if you add in omega-3 index, it's like next about as good as diabetes, and second only to HDL with respect to its predictive power. So this is a really important study that was published recently, and it was looking at, this is a large database based study looking at omega-3 levels, circulating omega-3 levels in the bloodstream of docosahexaenoic acid, DHA. We also looked at EPA as part of it, and risk of all-cause and cause-specific mortality. So it's a giant study. Again, I think there was 180,000 people followed about 13 years from 17 different cohort studies that were harmonized, kind of reanalyzed the data using the same quintiles of lowest to highest levels of omega-3. And then we, look at causes of death. So in this study, these are the various causes of death we analyzed, and on the upper left here, that's all-cause mortality. And you can see going from the first quintile, which is the lowest level of omega-3, to the top quintile, there was about a 17, 18% reduction in risk of all-cause mortality with a microscopically small p-value. I mean, there's no question about it. This is a powerful predictor of all-cause mortality. And again, so modifiable. It's like how many things can you do that you just take an over-the-counter supplement that's pennies a day that will reduce all-cause mortality? And if you go from quintile 1 to quintile 5, it was like about 20% reduction in all-cause mortality. CVD mortality was also even more powerful as you get into that top quintile. And in the top quintile, again, you have to have a omega index of about 7 or 8%. And again, so you'd be talking maybe, well, by definition, only 20% of people would have an omega-3 in that level above 7%, and it reduced. So it was associated with a reduction in cardiovascular mortality over 13 years of about 22%. Cancer mortality was also reduced about 20% in the top quintile, and even other mortality, non-cancer, not heart disease mortality. It also reduced those things like respiratory disease mortality and other various things, neurodegenerative type stuff. So it's another relatively new study. It's only less than a year old, looking at omega-3 blood levels and stroke risk. This is another pooled harmonized force analysis of that also included some UK Biobank, but it's 29 prospective studies. Again, Nathan Tintle, our biostatistician, does amazing work on harmonizing and equalizing these data, so we come up with really, really solid biostatistics. So, because it's a question, some people said, well, omega-3 might increase risk of stroke because, like in the Eskimos back in 1970s, when Bang and Dyerberg were first described this reduced risk of cardiovascular disease in Eskimos who were eating, tons of whale blubber and seals and fish and had a very high omega index. They didn't get any heart disease, but they did have an increased risk of hemorrhagic stroke. So the question is, like, what does omega-3 levels, how do they correlate with ischemic and hemorrhagic stroke? Well, here's the data. Total stroke down about 17% in the top quintile versus the bottom quintile, with a sort of graded linear decrease in risk. And ischemic stroke is even more statistically significant. You can see, and this is the upper right hand thing. Over here in the hemorrhagic stroke, there was no increase or decreased risk of hemorrhagic stroke, because the risk was about 1.0, which means there's no statistically significant increased risk of hemorrhagic stroke. Now, keep in mind, to get in the top quintile again here, you'd have an omega index in the 7 to 8% range, and that'd be correlated with only a consumption of 1,000 milligrams maybe of EPA and DHA, whereas these Eskimos would be eating much, much higher doses, like 7 or 10 or 15 grams a day of EPA plus DHA. But again, this was 14 years of follow-up, 10,500 strokes during the follow-up, 183,000 patients. I mean, it's really, really solid data with very, very significant p-values, except of course for hemorrhagic stroke, which was not different. So, yeah, the take-home message from this was that you could see here again, just in a different way, that total stroke and ischemic stroke 17 to 18% lower by just keeping your omega-3 in the top range, which might explain why we, like omega-3 in large doses might increase risk of atrial fibrillation. But even in the prospective randomized studies, even the people that increased risk of atrial fibrillation, it did not increase risk of stroke. And normally AFib increases risk of stroke, but it might be the stroke prevention sort of effects that omega-3 have that help to prevent stroke, even if you have AFib. Dr. Chin is going to talk to you about the atrial fibrillation story, so I won't spend much time on that, but I was a co-author on that paper showing that omega-3 index being the top quintile did reduce risk of atrial fibrillation, despite the fact that higher doses, like in randomized placebo-controlled studies, seem to that omega-3 intake would increase risk of atrial fibrillation. It's kind of a conundrum. In this study, this just looks at EPA, DAPA, DHA, and the combination of EPA, DHA, that the reduced risk of atrial fibrillation was about 10 to 13%, and highly statistically significant among 54,000 people, followed for 13.3 years. So we have redone that data with the UK Biobank, and found that a similar sort of findings. This is a paper that's under review right now, but we found that with increasing omega-3 levels in the bloodstream, you have a reduced risk of AFib, which again is very paradoxical, because the meta-analyses showing that fatty acid supplementation at higher doses, like in the randomized placebo-controlled trials, there was about a 25% increased risk. It was a dose-dependent thing. So the higher the dose of omega-3, like when you get about 4,000 milligrams a day, the risk was more like 1.49. And in lower dose, like around 1 gram or so, it was just borderline elevated. So it's really hard to kind of, for a lot of people, to sort of reconcile those two things. I mean, these are very, very well done studies, and with very opposing results. And my explanation for it is that, and we've written a paper about this, about the effects of omega-3 on atrial fibrillation are a double-edged sword that's vaguely mediated. At low doses, very low doses of omega-3, less than 250 milligrams a day of dietary omega-3, you have a higher risk of AFib, and at very high doses, you also have a higher risk. But in a medium dose, like 250 to 1,500 milligrams a day, is kind of the sweet spot for preventing AFib. And it's probably because the omega-3 intake also has a dose-dependent effect on vagal tone. We want high vagal tone. As a cardiologist, this is one of the things I really look at, things like beat-to-beat variability, or resting heart rate, or how high you can get your peak exercise heart rate, how quickly it recovers after exercise. These are markers of high vagal tone, which correlates with good cardiovascular health, reduced all-cause mortality, improved immunity, improved mood even, so we want high vagal tone, but in this case, so if you take a moderate amount of omega-3, you get a moderate amount of vagal stimuli, which reduces atrial fibrillation and stroke and mortality. But real high doses, if you're predisposed to atrial fibrillation, high vagal tone can predispose to increased risk of atrial fibrillation. So in a small subgroup of people, say athletes or people who have bradycardia at baseline or a history of atrial fibrillation, bigger doses, like about 1,000 milligrams a day, will stimulate the vagal tone and increase risk of AFib. So it's just one subgroup that we're careful about not using high dose omega-3. And this is another paper we've recently published, and we have another one even larger than this coming out, associating plasma omega-3 levels with new onset heart failure or death if somebody has heart failure. This was recently published, and here's the data. Again, these are sort of like recurring patterns now that you're getting used to seeing. But on the left is incident heart failure. That's new onset heart failure during 13.7 years of follow-up in 271,794 participants. Massive database. And you can see when we go from low levels of omega-3 to high levels of EPA plus DHA, the risk of this DHA in the blue and the mostly EPA in the red, these are statistically significantly reduced. And so in other words, like a 20 to 30% reduction in risk of new atrial fibrillation in people, sorry, not new AFib, but new heart failure in people who have high omega-3 levels, and all-cause mortality in people who have existing heart failure. That is, the 271,000 people at baseline, a few thousand of them had a diagnosis of heart failure at baseline, and then during follow-up, there was about a 50% reduction in all-cause mortality in people who had adequate levels of omega-3. This is a recurring theme, actually, that omega-3, among the things it's important for, is reducing things like all-cause mortality, cardiovascular mortality, mortality from heart failure. So it's a really important thing. We've written 3 papers now on this topic about omega-3 as an overlooked evidence-based therapy for heart failure. Back in the Lancet, way back in 2008, there was a big randomized placebo-controlled trial of about 7,000 people followed about 4 years, got about 850 milligrams of EPA plus DHA or placebo. And if you look at per protocol analysis, there was about a 14% reduction in cardiovascular death or hospitalization during the 4-year study in the people who got the omega-3. And this is the placebo-controlled trial. So in that trial, the number needed to treat to reduce 1 death during the study on taking 1 capsule of purified omega-3 per day was about 56 people you treat with that you'd save 1 life during the 4-year study. And for hospitalization for heart failure is 1 in 44. So, really pretty impressive data that is corroborated by our fatty acid measurement studies showing that high omega-3 levels correlate with lower risk of AFib. So there's other studies showing that omega-3 fatty acid by quartile is strongly associated with reduced risk of sudden death. And omega-3 as a risk factor for coronary disease, just showing that the risk of MI goes down as the omega-3 index goes up. And all the omega-3s tend to be beneficial, but EPA and DHA are the 2 that are most imminently modifiable. So those are the ones we focus on. It's also reassuring that we have a lot of prospective placebo-controlled studies showing that omega-3 reduces risk like major cardiovascular events. This is maybe the most impressive omega-3 study ever done. This was about 7,200 people followed for about a little over 5 years, randomized to 4 grams of icosapent ethyl EPA. So it's just a purified form of EPA versus placebo. And these people had a highly statistically significant 26% reduction in MACE. Kind of mentioned this before, but looking at change in absolute risk, this reduction of absolute risk of 4.8% in the REDUCE study is more than most of these other major studies that we look at, other various things like on ezetimibe or empagliflozin or the PCSK9 inhibitors. In other words, this made a really strong difference in absolute risk, omega-3. These are the various parameters in REDUCE it, where it reduced cardiovascular death and non-fatal MI, hospitalization for heart failure. It reduced them across the board. Death from any cause was borderline, reduced 13%. In that study, it was interesting that the people with triglycerides above 200 seem to get especially strong benefit and I do use omega-3 as my primary treatment for people that have high triglycerides. You have to use higher doses, like at least 2,000, if not 4,000 milligrams per day of EPA and or DHA. And you can get that generically now, even the EPA you can get generically, so it's pretty affordable. We often use it with statins to help reduce overall cardiovascular risk. Those 2 complement each other nicely, a statin with EPA, DHA. For my cardiac patients, I usually shoot for about 2,000 milligrams per day of EPA plus DHA. For somebody who's eating a lot of fish, less, maybe 1,000 per day. So I don't have time to go through the specific things too close, but I did want to point out that I emphasized this earlier about the omega-3 risk of cardiovascular death in major studies. A lot of these studies, that's the kind of common denominator, is they reduce mortality, whether it's all-cause mortality or cardiovascular death. And there's good biologic plausibility for that because it augments vagal tone, which is a good safety net for preventing cardiovascular mortality, and it also helps to reduce atherosclerotic cardiovascular disease. It helps to reduce inflammation, which is the primary driver of a lot of cardiac events. So the we kind of talked about the effects of omega-3 on vagal tone. This is a study Bill Harris and I did almost 20 years ago now that showed that on omega-3 we saw improvement in things that lowered resting heart rate. It improved post-exercise heart rate variability. So yeah, so just to summarize, I think that that omega-3 is like one of the key modifiable risk factors in heart disease, and that it's easily modifiable, it's safe, it's inexpensive. We typically we do measure the omega-3 levels at baseline, so that really helps for behavior modification, and especially for people who have existing cardiovascular disease or risk factors for that. We emphasize the omega-3, and it's, as I mentioned earlier, it's really an underutilized therapy. I think if you look at the data, if you look objectively at the placebo-controlled studies, when you do a meta-analysis of it, I mean, it reduces cardiovascular death and cardiovascular events. And when you look at the observational data, like we have in these powerful, large databases followed for 13 or 14 years, and statistically adjusted very carefully, you see these very impressive results. So, as a clinical cardiologist, it's something I ask every patient I see, like, how much fish do you eat? Do you take omega-3? Have you ever taken omega-3? Do you have trouble taking it? We usually can find a way to get people on it. And as healthcare providers, I think it's really important that we ask about this and emphasize it, because most people are not emphasizing it. A lot of people are taking it just because there's been so much data in the past 30 years emphasizing its benefits. But with this recent sort of pushback on atrial fibrillation in a certain subgroup at high levels, a lot of people have just stopped taking it. Their doctors have told them to stop taking it, but I think it's a real missed opportunity for improving long-term health. And yeah, I think I'll stop there and be happy to discuss any related issues or answer any questions.
Thanks, Doc. Great information. Let's go ahead and dive into the questions. They have about 6 questions there, but as I've seen with these, there's always going to be more questions that keep getting added. So first question that comes in, is there any concern for high dose omega-3s in athletes who are also known to have a history of AFib, or is this or a situation or not?
I mean, I think Dr. Harris and I and some of our collaborators probably have a better, like Dr. Chin, have a better feeling for this than anybody, because we've done a lot of studies on it. And it's my personal opinion that it's real. Omega-3 does dose dependently increase vagal tone, which for most people, like I say, is a really good thing. But if you're an athlete, and I see a lot of athletes because I've also written a lot about the dangers of excessive extreme aerobic exercise, like people who are doing marathons and full distance triathlons, into their 40s and 50s and 60s and beyond. They have a very high rate of atrial fibrillation, and it probably can be. In fact, I have one patient who's sort of a poster boy for it. Like, he's a 62-year-old guy. He's a really avid exerciser, and he started taking 2 tablespoons of liquid omega-3, which was like would be 5,000 or 6,000 milligrams of EPA plus DHA, and he turned up for the first time with atrial fibrillation. He's doing 70-mile bike rides on the weekends, and he's super fit, and eats really healthily. He doesn't drink alcohol, doesn't have sleep apnea, doesn't have any of the other risk factors for atrial fibrillation. But so we talked about this. We said, like, have you changed anything? Well, I am taking more omega-3. So I told him, oh my God, that's probably what it is. So we stopped his omega-3. He was having intermittent atrial fibrillation. It wasn't persistent. And we stopped his omega-3 and then eventually put him back on just like 600 milligrams, which we've learned, like, in the observational studies, a dose of about 600 to 700 milligrams of EPA plus DHA per day correlates with a lower risk of AFib, and then doses above 1,000 or 1,500 milligrams dose dependently increase the risk, which really goes up when you get above 3,000 or 4,000 milligrams a day. But this is a small subgroup, So that most people, you don't need to worry about it. Most people, you want high vagal tone, and so but in an endurance athlete who's had a fib, I'd be careful not to use more than 600 or 700 milligrams a day of supplemental omega-3, and they could get that easily by eating salmon twice a week and not taking a supplement.
Question is really more about personal use. Do you personally supplement with omega-3? And if so, how much?
Yeah, I am like I have taken omega-3 for the last, I suppose 20 years. I've never had AFib. I am like a very enthusiastic exerciser, but I've learned to like do some yoga and some other things. I'm careful to not drink too much alcohol, because alcohol is a very strong predictor of trigger of atrial fibrillation. In fact, previous generations of cardiologists called atrial fibrillation the holiday heart syndrome, because after the Super Bowl or 4th of July or Thanksgiving or Christmas, people would show up in the ER with atrial fibrillation. And so yeah, it's I take about and I eat fish like at least once a day, and it's usually salmon or sardines or scallops or shrimp, and it's not fried. And I still take about a teaspoon of liquid omega-3, which is about 2,500 milligrams of EPA plus DHA per day. I mean, I find it helps with my sore joints and muscles after working out. And it's also really good for the brain. We didn't get into that, but like omega-3 correlates strongly with keeping your brain plump and not shrunken as you get older. It correlates with, we have a study under review right now showing that omega-3 intake correlates with reduced suicidal ideation. There's other studies showing that reduced successful, like when somebody commits suicide or goes on a shooting rampage. If you measure their omega-3 levels, it's pretty predictably very low. So it's a simple thing to do. My omega index, I like to keep it above 8. It runs anywhere from 7.5 to as high as 11.8%. And yeah, so I definitely practice what I preach when it comes to omega-3.
I've noticed that high dose omega-3 supplementation increases LDL cholesterol in some people. Can you speak to this?
I mean, it can slightly increase, but to the extent that it does that, it's kind of a calculated thing, because it lowers triglycerides pretty powerfully. And so if you lower triglycerides, in the Friedewald equation, you sort of also increase the calculated LDL. But there's a lot of good studies showing that it's anti-atherosclerotic, and you can regress coronary atherosclerosis, especially the oxidized LDL and triglycerides out of the plaques in the arteries by high dose omega-3. So, I mean, that being said, it's like omega-3 is not a treatment for LDL. And if you're worried somebody has plaque, they need to be on therapies like statins or ezetimibe or PCSK9 inhibitors, or all three. We use those medications a ton and drive the LDL down generally under 55 in people who have high risk. So, it's not a problem. The practical problem, omega-3 increasing LDL is not a major issue.
Talk about plaque regression. So this is a good question, I think. Are omega-3 index levels higher in patients who have primarily calcified plaque and lower in patients who have soft plaque or rich lipid cores on NIRS or intracoronary ultrasound?
I'm not aware that there are studies showing that the omega index is correlated with like a lipid versus a calcified component of the plaque. I mean, we do work hard to keep that LDL and triglycerides down, and use an antioxidant diet to kind of, as I say, leach the lipid-rich, pro-inflammatory triglycerides and LDL out of the plaque. So, but I'm not sure that the omega-3 index, if Bill's on, maybe he could comment on that if he knows any data on that.
There's a question from, you probably know who's going to ask this question. Do you see any hope for a joint American Heart Association ACC position paper endorsing the use of omega-3 for cardiovascular disease prevention? What would it take to make this happen?
Yeah. Yeah, there's so many like deeply ingrained skepticism about it. I'm grateful that the HA still recommends 1 or 2 fish meals a week to keep your omega-3 levels up, and if you can't eat fish, that and if you have heart disease, that an omega-3 supplement's a reasonable thing to do. To me, the data are so strong, and the fact this controversy about the atrial fibrillation, that it increases atrial fibrillation in people with bradycardia and high vagal tone is kind of the exception that proves the rule. It One of the things it does, besides lower inflammation and improve vascular function and lower blood pressure and reduce platelet aggregability, is it augments vagal tone, and vagal tone is a strong correlate and driver even of things like all-cause mortality and cardiovascular death, brain health, mood, all these things that we see positive things from. So to me, there's no question that like we have solid data, randomized placebo-controlled trials with a meta-analysis. That's the top level of evidence, is meta-analysis of large, well-done randomized placebo-controlled trials. And when you do that, you see that there's no question highly statistically significant cardiovascular benefits and mortality benefits in people with high omega-3 levels. So, and then we have all this data related to blood levels and omega-3, which, this observational data, but to me, it's kind of like observational data like blood pressure. I mean, blood pressure, we observe blood pressure, and changes in blood pressure have strong correlations with subsequent cardiovascular and all-cause mortality. And we see the same thing in large, well-done observational studies that we and others have done. So it's super important, and I wish they would come out with it. And eventually they will, because data always wins out, and this data is is very consistent. Although, if you do smaller doses and not enough people and not long enough trial, you come up with a negative result. And then people say, oh, I guess omega-3 doesn't work. But if you put it in the context of like large randomized trials and observational studies, it fits perfectly well, and it's super important.
For someone on a vegan diet to reduce triglycerides, what dosing of EPA DHA would you suggest?
So that's an important question that I that I often deal with in vegans, and and these are people like the people who hate fish or the people who are vegans, like they're the ones who need the omega-3 the most. They will have predictably very low omega index levels and increased risk for, brain problems and other issues. And so you can use algae based DHA, and still follow, a vegan diet. And I mean, somebody like that, I mean, I would say they need at least 1,000 milligrams of DHA. And I usually talk them into taking EPA plus DHA because they have different benefits, and the change from one omega-3 to others is relatively low uh, in a in vivo, in your system. So it's really good to take both. But yeah, I really emphasize in vegans that they need to take. I also talk them into things like animal protein, like in the form of, sort of ethically raised hens who are producing eggs and kept in humane conditions, because the animal protein, I think, is very important for just maintaining muscle mass and building strong bones and everything else.
Let's see. Can taking too much omega-3 supplements cause cholesterol changes, or especially cholesterol to increase?
No, you shouldn't see increases in total cholesterol with omega-3. Like you say, you might see a mildly increased LDL if triglycerides are going down, but no, that's not a worry. Too much omega-3. The main thing is the AFib risk in a certain subgroup. It can, when you get above about 7,000 milligrams per day, it can also start increasing bleeding risk, but that's like a dose that we never use them. It's to be a really massive dose. That's sort of Eskimo dose. And you can start getting increased bleeding risk with that. The yeah, so it's pretty forgiving that way.
This relates.
Higher doses do correlate with like reduced inflammation in the brain and the blood vessels and whatnot. So, like I say, I tend to tell my patients try to get 2,000 milligrams of EPA plus DHA daily.
Just a few. We have about 8 more minutes, so we're going to try to get through as many questions. So no more new questions, as we probably won't be able to get to that. Does the vagal tone hypothesis help resolve or explain how EPA-driven MACE and CVD death reduction benefits found in reduce it, have occurred despite the omega-3 index being dominated by red blood cell DHA levels?
Yeah, that's a really good question. But like both DHA and EPA will favorably affect vagal tone. There was a study here at the University of Kansas in Kansas City here where they looked at pregnant moms and supplemented with either 200 units of DHA or 800 units of DHA. And in the moms at the end of the pregnancy, they had much better vagal tone, better beat-to-beat variability and better post-exercise heart rate recovery and other parameters of vagal tone. But I think that because when you look at in the reduced, the benefits have occurred pretty quickly, and these changes to vagal tone can happen pretty quickly as well. So I think the vagal tone, which by the way, nobody is talking about. I mean, we wrote the first paper about this, and even now, like you don't hear anybody talking about it, and it's so important. I mean, this is like you want a high vagal tone. It improves all-cause mortality and mood and brain function and heart function. And like this is an easy way to do it. And it also explains this paradoxical increased risk of AFib in some people.
Trying to see what the next question is. A couple of different questions. Any sense for what the omega-3 index in these athletes, especially endurance athletes in particular, who thus might be at a higher risk of AFib? Might this be that is ideal less than 8% for them to have a lower omega-3 index score, I guess is the question.
Yeah, I don't know specifically the answer to that question, but like if you look at 600 to 700 milligrams in our study where we saw you kind of got the between 600 and 1,000 milligrams, you got the optimal reduction. It was associated with the optimal reduced risk of AFib. That would correlate with omega index of around 7%, I think. Bill would be answer that question better, but I think so I would say in people who have a risk of AFib, 50-year-old who's doing full distance triathlons, I would probably keep it not much above 8 or 8.5%, but that's just an intuition.
Could you comment on your article with, and I'm not going to try to pronounce this last name, D. Nico Latonio, about omega-3 stabilizing.
Yeah.
About omega-3 stabilizing plaques vulnerable to rupture.
Yeah, I mean that's an important study, and it's been replicated many times. Maybe the most dramatic was in some people who were getting ready to have a carotid endarterectomy. It's over in the UK, and so so it was scheduled for when they scheduled, they had to wait like a few months, if not several months, before they got it done. And they randomized people to about there's a pretty high dose of omega-3. I think it was like at least 3 or 4 grams, and versus placebo. And then they looked at the plaque composition of the carotid, rind that they took out of the surgery, 3 or 4 months later, and they saw, dramatic improvements in lipid core, inflammation, even severity of the stenosis in the people that got the omega-3. So it does, really powerfully influence plaque composition and inflammation in the plaque. And that's probably part of how it reduces cardiovascular events and reduces risk of ischemic stroke, myocardial infarction, and sudden cardiac death.
Just a few more questions. It seems like the effects on heart failure may be the lowest hanging fruit to get the cardiology community on board with omega-3. What other agents as safe as omega-3 are available for reducing risk for death in heart failure patients?
Well, heart failure is like a real hot topic these days because it's so prevalent, both heart failure with preserved ejection fraction, which is half of the heart failure hospitalizations now, and heart failure with reduced ejection fraction. There's like 4 pillars that for the heart failure with beta blockers and ARB/ARNI and SGLT inhibitors and MRAs like spironolactone and eplerenone. And we make sure they're on all those, but and sometimes they need an ICD or cardiac resynchronization therapy. But again, low-hanging fruit, like we have not only this powerful observation data we're just publishing now in 2 big studies of hundreds of thousands of people that show a dose-dependent effect on reducing heart failure hospitalization, heart failure diagnosis, and also death during if you have heart failure. But it's there's a randomized placebo-controlled trial. I mentioned the JISI heart failure study where you saw these highly statistically significant practical benefits in a low dose of omega-3 in people with heart failure. So it should be, and we've written three papers on this topic now, and I think that that will start catching on because the data are pretty irrefutable and the downside is minimal. I think it hasn't thus far because it's just been there's so many other therapies that people, figure they'll just work on getting people on their SGLT inhibitor and on their Entresto and those kinds of things. But then, of course, the beauty of it in heart failure, it's also good for the brain and the immunity and the mood and all that stuff. So, yeah, I think it's super important.
What are your thoughts about the criticisms of the placebo selection in the Reduce trial? And what do you think about maybe the null outcomes of the Strength trial?
Yeah, really good questions. So they used a mineral oil as the placebo control in Reduce It, which might correlate with worsened outcomes in placebo, accounting for the difference rather than the benefits from the omega-3. And that might be part of it. I don't know. But even if you look at the randomized placebo-controlled trials, besides that, you still see this benefit, although that was the most striking of any of the trials. The Strength trial, which was a mixture of DHA and EPA in a large group of people, did not show cardiovascular benefit, so it was stopped for futility. I really don't know how to explain that other than, maybe it wasn't a big enough group or they didn't use the right dose or, but it is a paradox. But even with that, it's like if you put that into the meta-analysis of the 43 large randomized placebo-controlled trials, you still see that omega-3 has statistically significant benefits. And like I say, the gold standard for the highest level of evidence is a meta-analysis of all the placebo-controlled trials, and it clearly shows with high statistical significance that omega-3 improves cardiovascular outcomes.
Could you comment on how the data you've shared translated to complete medical nutrition solutions for patients who need them in context of, let's say, specific interventions like before and after cardiac surgery, cancer? The question is, how much omega-3 should be included for optimal nutrition?
Well, it helps to know where they're at. So I was asking them about how much they eat, but then if you get the omega-3 level, the omega index, then it kind of helps you to decide the dose. And I think for most people, I like to see their omega index above 8. And to get there for the average American, it takes about 1,000 milligrams a day. If you're in the lowest quintile, which a lot of Americans are, 20% by definition, you need more like 1,600 milligrams of EPA plus DHA per day. And that's just to get you into the top quintile. I mean, I think for a lot of these other benefits, that's why I like to go with 2,000 milligrams of EPA plus DHA. The cancer question, we don't have nearly as much data in that, but in our observational data of 183,000 people, it reduced cancer mortality significantly. And, we're writing a paper on that right now about the potential benefits in people with cancer or reducing the risk of cancer by keeping your omega-3 levels up. So, I mean, I think the average American needs about 1,000 milligrams of EPA plus DHA per day. And depending on if you have a risk for Alzheimer's disease, like people with ApoE4, which is about 1 in 4 people predisposes to Alzheimer's disease. And in those people, I tend to use, make sure they get at least 50% of the EPA of their omega-3 is DHA, and that they're getting at least 2,000 milligrams a day of total EPA plus DHA. And there's pretty good observational data to support that.
Yeah, and we just saw a study out of Baylor last week with looking at collegiate athletes that they were taking 24 to 2,800 combined EPA DHA per day and didn't see much of an increase in 8 weeks. So it's like maybe these high performance athletes need even more. Last question, and then we're going to close it out. How do you measure vagal tone?
So there's lots of different ways to do it, the beat to beat variability, and you look at the statistical variation from one heartbeat to the next, and you want it like you take healthy young athletes, for example, and they breathe in and the heart rate goes up and they breathe down and it slows down. You look at their ECG, it kind of looks like an accordion and it goes, so, but there's also like high vagal tone generally correlates with lower resting heart rate. People with high vagal tone tend to be able to achieve a higher peak heart rate. And then when they stop exercising the first minute, their heart rate should go down at least 15 beats a minute to you have high vagal tone, like a good athlete, somebody who's fit. I mean, you tend to have high vagal tone when you're younger, and it tends to become eroded with age. But even if you're taking omega-3 and trying to stay fit and eat a healthy diet, keep your weight normal, you can keep your vagal tone high. It helps to do things like, get outside and get your sleep, and don't drink too much alcohol, and do some slow deep breathing or meditating, things like that augment vagal tone. The simple way to do it is how quickly your heart rate recovers after exercise, and if you should be at least 13 or 15 beats per minute in the first minute. And the more precipitous the drop, the higher your vagal tone is.
Excellent. Dr. O'Keefe, thank you so much for sharing your expertise today. Great presentation. Really appreciate your time.
Thanks.
Dr. Frank. Oh, sorry. Go ahead.
As you said, thanks for the opportunity, and thanks everybody for tuning in.